Hi, my name is Brandon Ayres. I'm from the cornea service at Wills Eye Hospital. My private practice is called Ophthalmic Partners in Pennsylvania and New Jersey. For the next hour or so, we're going to talk about non-capsular IOL fixation. These are my financial disclosures, nothing that will impact the subject matter of today's course. Now, the description is going to be a video-based discussion on placement of a PC IOL when there's not enough capsule to hold it there. So naturally, we're going to be talking about suture fixation or IOL fixation techniques. Now, all of this is going to be off-label. There is no IOL that is on label for not in the bag fixation outside an anterior chamber lens. And it's important to understand when we're talking about these techniques, you should never operate outside your surgical comfort zone. So if for you an anterior chamber lens is the way to go, then that's what you do. But if you want to learn some more techniques for sutured PC IOLs or posteriorly fixated IOLs, this is the course for you. So when on earth would you actually need to use scleral fixation? Why do we even need it? Well, there's several instances where I think a scleral fixated PCIOL is going to be an advantage. One is we're seeing more and more dislocated IOLs and dislocated IOLs in the capsular bag, and that's going to come with inadequate capsular support from, say, a collagen vascular disease, from prior vitrectomy, from trauma, refixation of previously sutured IOLs is coming up. So somebody already had a sutured lens, maybe with polypropylene, and now that suture has broken for whatever reason, we have to go back and refixate it. And most of the dislocated implants are going to remain in the anterior segment. So an anterior segment surgeon can probably get to about 90 to 95% of these IOLs without really requiring the help of a retina surgeon, assuming that the vitrectomy is already done or the surgeon is comfortable performing a fairly complete anterior vitrectomy. And what if you have a patient like this where you've got a combination of aphakia and significant iris damage? Here you really don't have an anterior chamber lens as an option. It's going to be some kind of a suture fixated PCIOL or maybe an aphakic contact lens in this case. And as I've said before, the traditional anterior chamber lens, the modern anterior chamber lens, is still a good option. And there are lots of papers that show that the clinical results from a well-positioned anterior chamber lens as compared to a sutured PCIOL or haptic-fixated PCIOL really is no different. So if you're good at placing ACIOLs, it is still, I think, a viable option. Now, if we're going to start doing fixation techniques for the posterior segment, you're going to need some tools. And one is you're going to need some anterior segment instrumentation, microforceps, needle holders, some specialized suture. We use a lot of the polypropylene sutures or 10-O-Prolene on a variety of different needles, straight needle, curved needle, single arm, double arm. We're also using more and more in an off-label way Goretex suture. The Goretex suture is the CV8 or cardiovascular 8 suture. It usually comes on what's called the TTC9 needle, which is a vascular needle. Now, often we'll cut the needle off and not use it, but some surgeons do like to use that needle. It's the equivalent of about a 7/0, so it's quite a thick suture. It's monofilament, and it's really, really slippery, so it does take a little practice to learn how to use that suture. So let's start by talking about Ayres fixated IOLs. This is one of the nicest and simplest techniques for dealing with maybe a dislocated three-piece IOL that's already sitting up in the sulcus but doesn't have enough capsular support to hold it in place. So very helpful when the IOL is out of the bag and in the sulcus. We commonly see this when somebody has already had some compromise to the anterior posterior capsule during surgery, and then a sulcus IOL was placed. Initially looked pretty good, but then some days, weeks, months, or even years down the road, that haptic finds an area of zonular weakness and slides through and then becomes dislocated. So here I do like a rounded anterior lens. I don't like the square edge implants just for fear of chafing on the iris. And myself, I'll often use acrylic or silicone IOLs. A lot of surgeons will recommend a silicone as it's very soft on the iris, but as long as I have a rounded anterior edge, I'm okay with silicone or acrylic. So how we're going to do this, and here you see a little animation of this. This IOL is dislocated, but in the sulcus. we're going to have to get in there and reposition the lens. Now, sometimes there is adequate support to hold an implant in a certain location, but three-piece IOLs are going to slowly pinwheel in the sulcus, and so just repositioning is not usually enough to hold it in place. But if we put a couple sutures through the iris and around the haptics to prevent that implant from rotating, now we can use a combination of the polypropylene sutures and the haptic to keep that implant in place. So let's see how this looks in action. And here we have a dislocated three-piece IOL. Now it doesn't look too bad in the video because the patient's lying back. When this patient were to sit, if this patient were to sit up, you'd see that implant begin to sunset on you. We've already repositioned or rotated the IOL, so it's now holding itself centered, and we're going to start placing our 10-0 polypropylene sutures. Now, I do prefer the curved needle, the CIF4 needle, for doing suture fixated IOLs. And what you'll see in this video, and I've paused it, is that we have the optic of the IOL prolapsed anterior to the iris. But the iris is not constricted very well. I would not recommend using any kind of intracameral phenylephrine or epinephrine in these cases, and I don't give these patients cyclogel to dilate them because it doesn't let the pupil come back down. So I've given this patient a miotic agent, and I just can't get good constriction. So I've actually placed a microforcep underneath the optic of the IOL, and I've reached across the anterior segment, and I'm grabbing with a microforcep to pull on the iris because I want to try and get this suture through a small amount of iris as peripheral as possible. And there's also a flag on the play here, and that's what I'm going to show you right here. Now, if you look at the picture in front of you, I've got my three-piece IOL, and I'm passing my suture through a paracentesis underneath the iris, underneath the haptic, and then back out through the iris. But instead of suturing into the curve of the haptic, I'm suturing on the outer curve, if you will. And that makes it a little bit harder to incorporate a small bit of iris. You'll tend up getting more iris there because the iris slides over the haptic. So if I were to place my suture this direction or into the curve of the haptic tends to hold the iris for you. It makes it a little bit easier to get a small bite. You can suture either way, but to make your life easy, I'd recommend suturing into the curve of the haptic on both sides. Let's continue on with the case. So we'll see we're grabbing that very small, very peripheral bite of the iris, incorporating the haptic of the IOL. You can then push the needle either through a paracentesis a few clock hours away, or you can push the needle right through the limbus, which is the option that I've taken here. Now on the other haptic, this time I'm going the right direction, so I'm suturing into the curve of the haptic, and you can see I was able to get a very small bite of iris. Now we have both haptics captured with the polypropylene suture, and we'll go back and we'll recover one side of that suture. Now here you have many options. You can tie this in a classic mechanical type suture, or you can tie a sliding knot. Certainly a mechanical suture is going to be technically a little bit more simplified. You're simply tying a 2 or a 3-1-1 through a common paracentesis, and that works very, very well. If you are not able to find a paracentesis or don't have a paracentesis that will work well, you can tie a sliding knot. I'm not sure that one has a strong advantage over the other, but a mechanical is certainly a little bit easier to tie, and there's a little bit less suture spaghetti to deal with. Now what's critical is right here. We now have both haptics tied. You want to push the optic back. You do not want to rotate that IOL. If you rotate the implant, you can actually slide the haptics right back through your sutures, and you'll dislocate the implant again. So simply pop the optic back by pushing down and prolapsing it through the iris. We'll then complete this, just making sure no vitreous prolapse with an anterior vitrectomy, and we're using triamcinolone to make sure that there's no strands of vitreous in the anterior chamber, and the case is completed. Nice round pupil. Now a little tip here. It is easy to ovalize a pupil when you're doing an iris sutured IOL. The things you want to focus on are biting the smallest amount of iris, keeping the sutures as peripheral as possible, and then after you have sutured the implant, you want to pull on the iris to pull any fibers that have been incorporated into the suture out of the iris suture. So you'll see here, I'm suturing this implant correctly. This is a three-piece IOL, and I've got much better constriction on this. So you see that cat eye look where the optic is prolapsed anterior to the iris. The haptics are behind the iris. we've passed our suture, and we're going to tie, in this case, I believe, a mechanical. That little latch hook looking device is called a condensnaire. It's a device that is made for recovering suture, and it helps prevent you from catching a hook, like if you were using a Sinski or a Kuglin hook. It keeps it from catching on the paracentesis, which can sometimes be a problem when you're doing these cases. Yeah, so here we are tying our mechanical suture to fixate the haptic to the iris, and once that's sutured in place, we'll cut those ends quite short. We'll need to do the same thing on the other side of the IOL. So here we are passing our 10O polypropylene suture on the long curve or CIF4 needle. It's going to go through the iris, under the haptic, and then back out through the iris, right out through the other side of the limbus. And I believe in this case we're going to end up tying another mechanical style suture, just because my paracenteses worked out to be pretty close to where the knot was. You don't want to tie a mechanical suture through a paracentesis far away from where your suture is going to end up, because you're going to end up really torquing the iris and the IOL. So you want to keep them relatively close. Sometimes that means you have to make another paracentesis to draw the sutures out through. Not a big deal. What I'm doing here is using a little bit of a McAhmed technique where I'm tying or holding one suture inside the eye and one suture end outside the eye to really make sure that I can get that knot fairly tight around the haptic. And that's because my paracentesis wasn't that close to where I was tying the mechanical style suture. Now this is that critical pushback for the IOL. We're not going to rotate the implant. We're going to simply prolapse the optic back through the iris, so there's no rotation involved here. Then we're going to grab the iris where it looks a little ovalized and just tug, and that's going to pull any fibers that have gotten stuck in that knot out, and it's going to really help us round out that pupil. So small bite, peripheral bite, pull excess fibers out, and that's going to minimize your ovalization on an iris sutured IOL. Let's talk a little bit about dislocated IOLs in the capsular bag. So here you can't use the capsule because the capsule is dislocated, but we can reposition or refixate an implant that is dislocated, whether it's a one-piece or three-piece IOL in the capsular bag, even with a submarine ring. And we can do that by using an under-over technique where we're going to end up suturing a vertical mattress suture, incorporating the capsular bag and haptic on both sides. So to do this, you need really maximal dilation. So even in a well-dilated patient, you almost always need to use flexible iris retractors to expose the haptic of the IOL. In this case, I'm using a 25 gauge needle. I'm going about 3 millimeters posterior to limbus. I'm going into the eye, up from behind the IOL, underneath the haptic, and then anterior to the optic. We'll then take a 10O polypropylene suture. For this, I think the straight needle or STC6 needle works best, and we're going to pull that suture out through the sclera. Now we'll go about 1.5 millimeters anterior to that first incision, and we'll place the suture anterior to the haptic and out through the sclera. So we now have a horizontal mattress suture that incorporates the submarine ring, capsular bag, and haptic of the IOL. Now in almost every case, you're going to have to do the same suture 180 degrees away. I have tried to suture fixate just 1/2 of an IOL, and it almost always ends poorly. So what you do on one side, you're going to have to replicate on the other. And there are techniques now for using Goretex suture for this same technique, but you have to modify things just a little bit because of the needle and the suture size. But the theory is the same, where we're going to go deep to the IOL, about 3 millimeters posterior limbus, and then we're going to go anterior to the lens using a double arm polypropylene or whatever suture you're using to create that vertical mattress suture on both sides. Now, if you're using polypropylene suture, you can either leave the suture ends quite long and tuck them underneath the conjunctiva, underneath your peritomy, or you can rotate that knot into the sclera. I rarely create grooves or flaps for these. I just leave that suture on the surface of the sclera. And it does work pretty nicely, and you're able to keep your incisions quite small, but this technique is not without problems. Here's a very similar case, and you can tell what's going to happen because my video was labeled. But we're going to use an under-over technique. And you have to remember something that is behind that iris, a little organ called the ciliary body. And this ciliary body has blood vessels and they can bleed. And these under-over techniques with that needle can sometimes hit that ciliary body and you will end up with significant hemorrhage. So it's something to watch out for. And it's one of the reasons that I really don't use this technique nearly as much as we used to. So here we are, we think we're a hero. We've already fixated one half of the implant and I'm working on the second half. And it's on this last needle pass, the anterior needle pass, where suddenly I start getting a little bit of hemorrhage. You can see it in the anterior chamber right there, and that is going to eventually spread, it seems like everywhere, causing a vitreous hemorrhage and a little bit of a hyphema. I will tell you now, this patient recovered excellent vision, but it took about 6 weeks for it to recover because there was a significant amount of hemorrhage. No retinal tear, no retinal detachment, nothing else, just hit the ciliary body and caused a lot of heme. So then we end up going in and trying to aspirate it out, but as you guys know, blood clots pretty quickly and it's hard to get all of that out. So a well-positioned lens and good vision in the end, but a very frustrated patient for several weeks until that heme cleared. But still, a technique that I think is worth knowing because in the right situation, it can be very, very helpful. So let's move on to scleral suture fixation. And we've been trying different techniques for suture fixation for about 15 years now. And it seems like every time we find a technique that looks like it's going to be, the bee's knees or the cat's meow, we find some kind of a problem with it that sends us back to the drawing board. But let's talk about some of the general steps. So you want to set yourself up for success. Generally speaking now, we are doing sclerotomies 180 degrees across the visual axis, and you can do this from a temporal approach or from a superior approach. Your sclerotomies want to be 180 degrees across. I like to suture 3 millimeters posterior to the limbus, and I make 2 sclerotomies approximately 4 millimeters apart. Now the trend has been to go a little bit bigger actually, and some surgeons are now doing 4, 5, or even 6 millimeters, but I leave mine right at 4. Now these 4 millimeters very nicely match the shape and the spacing of the Bausch & Lomb Acryos A060 implant. But it works with many other implants as well. So let's show you this technique in action. So here we are, we've already measured a centration dot 180 degrees across the visual axis. And I have put trocars in, or I typically will put trocars in the proximal sclerotomy. That is just out of convention. I use those because they make the incision a little bit larger and it makes it easier for me in the end to bury my knot of Goretex into that sclerotomy. So I tend to do proximal trocars, distal stab incisions. In this case, we have an older style PMMA implant coming out. And now we're left aphakic. It's very important in these cases, if there's any vitreous left, to make sure you do an adequate vitrectomy. The worst thing we can do in this case is leave a patient with vitreous traction and lead to a tear and detachment. So you'll see here we are lacing our A060, Bausch & Lomb A060 implant with the CV8 Goretex. My preference is to pre-lace both haptics, making essentially mattress sutures on either side of the implant. So I will pre-lace it so once it goes into the eye, I really can't lose the implant. We'll fold it in a 50-50 fashion along the long axis of the IOL, and then place it in the posterior segment. Now, the implant is kind of fat. This is a hydrophilic acrylic IOL. Again, everything you're seeing here is off-label. So about a 4 millimeter incision will help you. I've got a 6 millimeter incision here, so that implant went in very easily, but you can get through with a 4 millimeter incision, and there are other techniques you can use where you can get by with a sub 3 millimeter. The most important part in this step of the surgery is to make sure that you have infusion on. That eye needs to be inflated. And then when you are tying your Goretex suture, I like to use slip knots, you need to adjust that implant so it looks and stays centered in the eye. The A060 implant is much smaller than the anterior segment, and you cannot pull that lens sclera to sclera like you can some other style implants. So you want that suture tension to be balanced, allowing the IOL to remain centered in the visual axis. and you need to make sure the sutures are not too tight so you're not stretching the implant. If you stretch the implant, it will begin to fold again, and you will see a significant amount of induced astigmatism as well as persistent inflammation in the eye. So that suture needs to be just tight enough to hold the implant in place. I'll then tie off my sclerotomies, close the peritomies, and of course close the main wound as well. Now here's another case where we opted to use the A060 implant. This is an IOL exchange. This patient had a vitrectomy not long ago, and now the implant shows signs of significant subluxation. When this patient sits up, you can actually see the implant in the visual axis. When the patient lies back, it drops back significantly. So I'm just making sure there's no vitreous by doing a pars plana assisted anterior vitrectomy, even though I knew this patient had already had a full PPV. And with the help of a macular lens or a Charles lens, I can see just that last zonule to be able to go back and get this implant. It was just hinged superiorly, giving us access to it. So I certainly would not recommend going back to the retina and picking up an IOL, but the use of the Charles lens allowed me to see just enough to get the implant pulled into the anterior segment. We'll remove the IOL and any sum ring. And now we'll go through the same steps that we just showed using the A060 implant and the Goretex suture, making our two mattress sutures. You'll notice here I've already removed the trocars. The trocar will actually hold the implant off. That's a 4mm trocar. And so the implant will not position properly until the trocars are removed. So once I get my sutures placed and I'm fairly certain I'm not going to need the trocar, then I go ahead and take them out so I can get proper centration. Once again, suture balance is of the utmost importance, and you have to do that with the eye pressurized. So anterior or posterior infusion, depending if you're working with an anterior segment surgeon or a retina surgeon, is absolutely critical, or you will get this implant wrong. Now, Goretex suture sometimes has complications. That knot needs to be buried. For a while, we were thinking that we could leave the implant on the surface as long as there was enough tenons, and that has not been the case. So I always bury my suture, and I almost always suture the sclerotomy, holding the knot to make sure it can't back rotate. And here what you're seeing is a sutured A060 implant where the Goretex suture has eroded through the sclera, or at least through the conjunctiva, causing chronic irritation, redness, and foreign body sensation. Now, this is not the end of the world. It is relatively straightforward and easy to refixate one of these implants if need be. Now, in this case, I did not want to use the same sclerotomy sites. As you can see, there's a little scleromalacia, a little blue sclera there. So I went 90 degrees away, 3mm back, and 4mm apart, and put in my usual sclerotomies. See, infusion is now in. Now what we can do is carefully grab onto the IOL, and this may require an assistant for you, because you need to hold onto that suture and pull it out. So it does take 3 hands. We'll now put this implant up in the anterior chamber. Now what's remarkable is that oftentimes with these exposed knots, the Goretex suture does not incorporate into the sclera. Other times, when the knot is buried properly, the Goretex suture will actually become vascularized into the sclera, and you can't even find it. So for some reason, when that knot is able to move and cause inflammation, it doesn't seem to incorporate very well. We're now passing a new piece of Goretex suture through the eyelets of the A060 implant, and we'll pull them through the posterior sclerotomies. You can see here I'm putting a Goretex suture through a paracentesis, through the first haptic, across to the second haptic, then I'll grab it on the other side of the eye. So we have a little basket that we're basically suspending this implant from so it can't fall posteriorly. We'll then push the implant posterior, we'll grab the suture so the IOL's in the proper orientation, and now we are back to a suture fixated IOL, and we'll balance our sutures, our suture tension, to make sure the implant stays centered in the eye. Again, I can't stress enough, notice the AC maintainer. This has to be done with a pressurized eye. The eye hates hypotony. Bad things can happen if the pressure drops with any of these suture fixation techniques. So here we are just recovering that suture. And then we'll pressurize the eye, balance our suture tension, and this case will be completed. So it seems as if we have a nice technique that holds an implant in place with very few complications. There's been lots of of papers written about safety with Goretex and accurate results using the A060 implant, but there is a problem, and that's the material. Not unique to the A060, it is universal amongst all of the hydrophilic acrylic IOLs, and that is when you expose the IOL to gas or air, surgical gas or air, especially on repeated bouts, you will get hydroxyapatite deposition in the IOL or calcification of the IOL. And this is just an example patient of mine who had a DSEC with this implant in place. We had to rebubble him 3 times, and sure enough, a couple of months after the surgery, he ended up with an area of calcification in the IOL right where the air is present. So that really shows the shape of his pupil there. And that's where we got the hydroxyapatite deposition. And I'd like to thank Dr. Liliana Werner for helping to provide these images of the implant for me. So this suture fixation technique really does have a very good record for safety, but opacification limits its use. And as somebody who's got retinal pathology or may need retinal surgery, I'm very hesitant to use hydrophilic acrylic IOLs as it may opacify. So what do we do to try and get around this problem? Well, we have to adapt and overcome. And can we use that similar or same suture pattern, 3 millimeters back and 4 apart, to suture a hydrophobic acrylic IOL? And one of the implants of recent that's been very interesting and helpful is the Bausch & Lomb MX60 and MX60E. This is a single piece hydrophobic acrylic IOL that has a little hole at the haptic optic junction. Again, that hole is not for suture fixation. It is off-label to suture this IOL, but we are able to lace this implant with Goretex suture using the same suture pattern and keep things relatively in place. And now we're not worried about calcium deposition if this patient should go on to need air or gas. So you can see in this case, we've already pre-laced the anterior portion of the IOL, and I've left the suture hanging out of the main wound. And I've learned that technique, and this makes things easier by leaving that suture tail hanging out of the main incision. I'm better able to ensure that the suture position over top of the haptic is correct. It is very easy to get these sutures twisted and end up with tilt. I use a horizontal mattress suture. Other surgeons will use a vertical mattress suture, and that will change how you lace the haptic. I like to lace that haptic so it goes over top of the haptic, underneath the little bridge, and then back over top of the haptic again. That way there's no induced tilt. The remaining portions of the surgery is very similar to the A060, where you have to maintain pressurization of the anterior segment. You need to balance your suture tension so the implant remains centered and just tight enough to hold the implant in place. If you suture too tightly, you will end up with problems. I still close the proximal sclerotomy or whatever sclerotomy is holding the Goretex knot, and then I close my peritomy afterwards. So this is suture fixation of the MX60 or MX60E implant. Here's just another case, similar situation where we're having a patient. You can see clearly he's got uveitis glaucoma hyphema syndrome. We're going to clear out the blood. And then measure to do our sutured A060 implant. Some little techniques here. This is one way if you don't have a LRI marker or some kind of a fancy sutured IOL marker. You just take something straight, put it right across the visual axis, and I make my limbo marks. That way I know I'm 180 degrees across the visual axis, and then we'll make our peritomies and do our 3 millimeters back and 4 millimeters apart based on those centration marks. And this little diagram shows how we suture fixate the MX60 or how we lace the MX60 for suture fixation. Again, drawing the leading haptic, pre-placing those sutures. The trailing haptic we will leave sticking out through the main wound so we can grab them later. And again, it just helps me make sure that those sutures are on top of the haptic on both locations. When you have the the four little haptics of the A060, you don't have to worry about this because there's no haptic swing. Here with the MX60, you do have to worry about it, and the spaghetti can be confusing, so these do take some concentration and practice and surgical planning. But the implant looks very nicely, and here we are just making sure and verifying that our suture orientation is correct. The suture is on top, above the little, above the haptic, underneath the bridge, and then over top the haptic again, with infusion in the eye. Again, this case is being done combined with the retina surgeon, so the patient's had a partial plane vitrectomy. We are making sure that we have good suture balance, not too tight, not too loose, with good centration. Now here's a case, a 62-year-old man who had a dislocated toric IOL, and this is one of the advantages of the MX60 that we don't have with other IOLs. 62-year-old man who had cataract surgery 7 years ago. 2 years ago, the toric IOL in his left eye dislocates. It's now been repositioned 4 times, most recently by myself, where I tried to do a reverse optic capture in the anterior capsule. It only held the implant in place for under 24 hours. The patient is adamant that he does not want to wear glasses and he doesn't want to wear contact lenses. The only clinical photo I have is here, where you can see the IOL at the top of the pupil margin, clearly out of position, and it's rotated almost 90 degrees from the correct axis. Topography, and remember this is the left eye here, shows a fair amount of astigmatism, and this is with the rule. So how do we treat this patient who really wants to be glasses free? Well, I fast forwarded the video to where we've already removed the primary toric IOL, which was well out of position. And we're going to try and suture a toric IOL back in place. But to do this, we first have to measure our intended axis, or the final IOL axis, and then rotate counterclockwise about 10 degrees for the suture axis. I'm going to measure back from the limbus about 3 millimeters and then measure 4 millimeters apart to make sclerotomies for the sutured IOL. Now in this case, it's going to be combined with a retina surgeon, as this patient's never had a vitrectomy, and I really wanted to make sure that suturing an implant and removing the bag in this place was going to be safe for the patient. We're still not really sure why the implant dislocated in the first place, as you can see an intact anterior rhexis, and the posterior capsule also appears to be intact. So just simply placing our first set of trocars around the axis that we're going to want to suture our IOL, and now we'll move on and do a quick pars plana vitrectomy. Again, this is not being done by myself, it's being performed by one of my retina colleagues. So after the vitrectomy is done, the bag can be removed, and this is simply done by grasping the bag and then removing it through the main incision. And what we found out by doing this was that there was a dislocated capsular tension ring in the eye. So we'll use a microforcep to carefully grasp onto the dislocated CTR, and then we can get that removed from the eye as well. So clearly there was some kind of a zonulopathy or issue during this primary cataract surgery. Now that the vitrectomy is completed, I'll make my second set of sclerotomies. And I'm going to start by handing myself a piece of Goretex suture. We're going to lace this around the bridge of the haptic on a toric MX60E IOL. The way that I orient the suture is over the top of the haptic, underneath the little bridge, then over top the haptic again. That way we don't induce any torque on the IOL. Now the trailing haptic I treat differently. I lace that outside the eye and I don't pre-place them through the sclerotomies. Now we can fold our IOL and carefully place it into the posterior segment. Notice that I've already removed the trocar where the implant is going to be pre-placed. Now the reason I do this is it helps prevent that trailing suture from getting all tangled up as this IOL opens inside the eye. So now that our IOL is somewhat placed, we're going to simply move the haptic, and I do like to keep this haptic hung up on the iris to make sure it doesn't move into the posterior segment. And now we can grasp our 2 sutures. By lacing and placing the IOL in this fashion, I can be very sure that both of my sutures are over top of that haptic. That way I reduce my chances for tilt. Once that second piece of Goretex is externalized, we can remove the trocar. Then all that's left to do is carefully balance our suture tension. and pray that our IOL is somewhat on axis. Now, I like to tie slip knots for these so that I can make sure that I don't over tension the suture. The MX60E has been implicated with some problems with suturing the IOL. The thought is that the material can't quite take the tension of the suture, and the little haptic, the little bridge in the haptic, can break. So I don't like to tie these too tight, just enough to hold the implant in place and well centered. Then we'll grab our knot, we'll bury it into the sclerotomy. I like to close the sclerotomy holding the knot to make sure it can't back rotate. This also helps prevent hypotony on day one. Once these sclerotomies are secured, we can then close the conjunctival peritomies. This can be closed with either Vicryl or cautery. We'll often use a 6-0 plain gut suture for this as well, as it seems to be a little bit more comfortable for the patient. But here at the end of the case, you can see our IOL is right on axis. All that's left to do is make sure our wounds are closed and watertight. Thanks for watching. So once again, just when you think you've got a great technique and it's safe to use in most patients, something starts to happen. And just recently, we've started to see reports of the little haptic bridge breaking, allowing dislocation of the MX60E implant. Now, this seems to be a relatively new problem, and we think when the MX60E was kind of born out of the original MX60, the material is just not quite as strong, and in particular the MX60E can dislocate. We think it's because the sutures were tied a little bit too tight, so keeping that suture tension just right is even more important. Now, you can always go back and suture a CZ70. The CZ70BD single piece PMMA IOL has been the classic sutured IOL for years and years. There's an eyelet on the haptic. That eyelet is for positioning, not for suturing, but in an off-label way, you can suture a CZ70BD. It works very nicely, but it's a 7mm optic, which means you need a 7mm wound. The suture setup is the exact same, 3mm back and 4mm apart. And there's a variety of different ways that you can lace the haptic of the CZ70 to try and prevent tilt. You can do torque and anti-torque, you can do cow hitch, you can do anything you want, but you want to try and minimize tilt with this IOL. You can see here, similar to the other IOLs, we are pre-placing our Goretex suture. You need to play a mental game here when you're lacing these sutures to make sure you're not inducing any twists in the suture, and make sure that implant doesn't flip or rotate on you while, between suturing one and suturing the other. That way when it goes into the eye, there's no induced twist. Now, the main disadvantage of the CZ70BD is that it's a big wound. So if you make a big wound, you got to close a big wound. But the implant does suture very nicely, and here you do not have to worry about balancing suture tension. As for the vast majority of eyes, the CZ70BD is going to be able to reach sclera to sclera, as you can stretch the haptics. So all you got to do is pull the haptic to the scleral wall and tie your knot and then bury your knot. So it's a little bit easier there as far as the small foldable IOLs, but you have to close and make a 7mm wound. Not the end of the world, but it definitely lengthens the healing time for your patients. And there's no toric available with the CZ70. Not that we're suturing that many toric IOLs, but that is one of the advantages of the foldable acrylic IOLs. So now fast forward. Who wants to mess with all this spaghetti and suture confusion and twists if you don't have to? So this became very popular. This technique became very popular. The Imani technique, devised by Shin Imani, won the ASCRS Film Festival Award, I think back in 2016, and has just exploded onto the scene. And this has largely replaced, for many surgeons, the glued IOL. And I'm not going to show the glued IOL technique here, as it's not one that I do very much. And the Imani technique, or intrascleral haptic fixation, has largely taken over for glued IOLs. Again, this is off-label. It's off-label use of the IOL and almost everything else in the OR. And just like for a suture fixated IOL, you want to set yourself up for success, and the measurements are a little bit different. You still want to measure 180 degrees across the visual axis. And I actually think and would stress that the measurements here are even more critical than in suture fixated IOLs. You're going to make your sclerotomy about 2 to 3 millimeters posterior limbus. I actually measured 2.5 millimeters posterior to the limbus, sometimes 3. And you want to measure a 2 millimeter tunnel length. That is the intrascleral tunnel length that you are targeting with a either 27 gauge trocar or thin wall 30 gauge needle or 27 gauge needle. The original Imani technique was described using a 27 gauge needle. Most of us will now use a thin wall 30 gauge needle. And then you'll need your low temperature cautery to eventually cauterize the terminal bulb on the haptic, preventing it from prolapsing back through the sclera and into the posterior segment. Now the IOL is critical. You want your IOL, long axis of the IOL, approximately 90 degrees from the axis that you measured across the visual axis. So this is the long axis of your IOL. And the reason we do that is to help make it a little bit ergonomically more comfortable for lacing the haptics of the IOL. You'll need a thin wall 30 gauge needle or a 27 gauge needle. It's helpful to have some kind of intraocular forcep. And something that we get questions on very often is, what IOL can I use? Well, truth is you can use almost any 3-piece IOL, but the implants that work best are implants that have a polyvinylidene fluoride haptic. That is either what used to be the EC3PAL and is now rebadged as the Zeiss CT Lucia. This is the only implant in the United States that has a PVDF haptic. So while I would say any 3-piece can be used, if it is your first go around with haptic fixation, trying to find an implant with a PVDF haptic is going to be to your advantage, as the other implants have PMMA haptics. Okay, it is not Prolene, they're PMMA, and they can kink and break and even pull out of the optic on you. So while you're learning the technique, make it easy. Use an implant that has a PVDF haptic. It's going to save you an awful lot of time and frustration. All right, so once again, across the visual axis, 2.5 to 3 millimeters. That tunnel length's about 2. You can see the IOL is already in the eye, so we're going to have our long axis across the eye. And let's see how this looks. Some other tips for you. Okay, you're going to want to have an AC maintainer. I think it's critical in these cases to maintain the chamber. You're going to want 2 paracenteses. If you're sitting temporal, you're going to have a superior and inferior. They're going to help you be able to manage the haptics inside the eye. And especially if this is not combined with cataract surgery, if you can rotate your main incision a little bit to the left, so a little bit of a left-handed incision, it makes it a little bit easier to get the trailing haptic. Because in this case, there's no question, the trailing haptic is the most frustrating and the most challenging part of this surgery. And by rotating that main incision a little bit to your left, it can make things just a little bit easier. Now, type of IOLs, we've already been over this relatively quickly, but any 3-piece IOL will work. But if you look at some of the platforms, the Alcon platform has a little extra curve on the haptic, and that extra curve is a little extra bend that you're going to have to overcome inside the eye. That does not make this IOL impossible to use, but it does make it harder to use. Other implant designs, the haptic ends in almost a perfect circle. It doesn't have the extra angulation, and that makes it a little bit easier to incarcerate or incorporate into the lumen of the thin wall 30 gauge needle. And again, if you can find an implant that has a PVDF haptic, that is going to save you some time. Now, the lumen of the needles, okay, the 27 gauge needle has a 220 micron lumen. A standard 30 gauge needle is 140 microns, and a thin wall 30 gauge needle is 200 microns. Now, a haptic average is about 150 microns. So if you're using a standard 30 gauge needle, this technique will not work. You have to use a 27 or a thin wall 30 gauge needle. Some people will actually use 27 gauge trocars for this technique. Several on our retina service at Wills Eye Hospital will use the trocars in place of a needle. Do not try a standard 30 gauge. It will not work. You'll just get frustrated. When you look at these needles, this is just a high magnification looking at the lumens. There are now some customized needles being made just for this technique, and I'll go over one of those needles in a little bit. All right, tips before you do this for the first time. So again, measure. Now I'm actually using a sclerotomy marker. So using an LRI marker, toric IOL marker to make sure you're 180 degrees across would be very helpful. That's a little sclerotomy marker that I'm using. It automatically marks 4 millimeters apart and 3 back. Now for a Imani technique, we want 2.5 to 3 millimeters back, and you want to measure out your 2 millimeter intrascleral length. So let's look at this. Our implant is going in. Here is our centration mark. Okay, the direction of the needle is going to go forward and backwards. It's going to follow the direction of the haptics, and you want to try and get a 2 millimeter tunnel even on both sides. Okay, centration and length of the sclerotomy are we're going to help determine whether the implant goes in centered or decentered, tilted or flat. And you're always going to do this with either anterior or posterior infusion. You'll see infusion is on. We'll enter the eye with our 30 gauge needle. Notice the anatomic bend to that needle. Then using your paracentesis so you can maintain your chamber, you're going to carefully grasp the haptic and place it into the lumen of the thin wall 30 gauge needle. You then actually let go of that hub. You do not externalize, or I would not recommend externalizing that haptic. Lace the second haptic first, okay? Get the trailing haptic into the lumen of the needle. And I'll show this again in another video. This is the most challenging motion or movement in this surgery. It can be very difficult to get that trailing haptic into the lumen of the needle. It looks easy on videos, but it can be very, very challenging. And this is where you're going to either kink, bend, or break a PMMA haptic. So again, if you can find a PVDF haptic IOL for your first couple cases, it's going to be to your advantage. Now that we have both haptics in the IOL, we can take the first haptic out. I'll put a little nub with cautery. We'll take the second one out, cauterize about 1 millimeter or so of the haptic, and now that cannot prolapse back into the eye. Now, industry has been very interested in trying to simplify this for surgeons because there is a lot of equipment that's necessary. This is a scleral fixation pack or kit that has almost everything you need for this technique. It includes the cautery, the thin wall 30 gauge needles that are actually custom designed for haptic fixation, AC maintainer, it has forceps for holding the needles, calipers, marking pens, almost anything that you would want for this surgery, all in one pack. So this isn't something that you do very often. If you find you need to use this technique, everything is in one place. You don't have to run around the OR, you just open up the pack. And it's really very nice, and we were hopefully instrumental and helpful in the design of what goes into this kit. So here you'll see those are the little custom needle holders. Now we'll move over to the patient and we'll start getting this surgery done. All right, so you're going to carefully measure again, and this actually comes with a little guide for placement of the sclerotomies. It even comes with a little caliper to measure 2.5 millimeters back and then 2 millimeters for your scleral length. So we're measuring the 2 millimeter intrascleral lengths here. AC maintainer. Make sure that you are pressurizing your eye. Now, it does not come with the implant, so you're going to have to provide that yourself. And it looks like I'm using a PMMA haptic. This is the custom needle. And notice there's no hub on it. The hubless design was really, really nice because sometimes the hub actually gets in the way of your fingers when you're trying to lace the haptic into the lumen of the needle. And so there's also a little silicone or elastomer band on the needle. So when you prolapse your IOL, you can slide that little band onto the haptic so you don't have to hold it or melt it right away. The remainder of the technique is very similar. We're gonna find the lumen of the needle with the haptic, and we're gonna marry those two together. And now we're gonna release the needle. And this is I think really nice here. We no longer have that very large hub on the thin wall 30 gauge needle kind of flopping around and getting in the way. So that keeps it out of the way. We'll then go the opposite direction with our other needle. Again, using the little holder. And now the challenging part, that trailing haptic, getting that trailing haptic into the lumen of the needle. The inferior paracentesis tends to work better for this, or your left-sided paracentesis tends to work better for this. Also, moving that main incision a little bit to the left, if you can do that, then you don't have to worry about making the paracentesis. This is pretty cool. You can use a little elastomer and slide it onto the haptic of the needle. That way you don't have to melt it right away and it won't prolapse into the eye. We'll now remove the second of the haptics. Make sure we like our centration, and if we do, take the elastomer off and cauterize the haptic. So some of the innovations coming from industry are making this technique a little bit easier for us to collect all the instrumentation, to make sure our centration is correct. The kit that I'm showing you is made by Microsurgical Technology. We were helpful, I think, in helping to design it. I've got no financial interest in it. And you know, if you want to talk to your MST rep, you can, but again, I've got no financial interest myself. What you'll see at the slit lamp are these little blue nubs. You want to try and get that haptic as into the sclera as you can. You don't want any exposure. And luckily, knock on some wood, I've not seen too much in the way of exposure of our haptics. But you do want to really help shove that haptic into the sclera. It's best if you don't even see the little blue nub of the haptic on the surface. Here's just one more example of using haptic fixation, and this is a case of a dislocated IOL. We're going to measure, make all of our measurements. You can see this time I'm not using any kind of a kit. I'm just using what we have in the OR already and the thin wall 30 gauge needle. This case is going to require at least an anterior vitrectomy to help elevate that implant and remove it. You can also see that very long tube shunt, which will end up being trimmed before the end of the case. I think the most challenging portion in many of these cases is getting these dislocated IOLs carefully and safely up into the anterior chamber without traumatizing the cornea or the anterior segment structures. So using a little shoehorn technique and a lot of OVD, we can usually get these dislocated IOLs up into the anterior chamber. And of course, the etiology of the dislocation here was pseudo-exfoliation. So removing the IOL, the capsular bag, the sumring ring as much as you can. Try not to drop the sumring ring if possible. That will require a PPV to remove. Just by infusing, there we go, some fluid, little OVD came out, and now using some triamcinolone and doing a pars-assisted anterior vitrectomy. Being comfortable with anterior vitrectomy is critical with any of these sutured IOL fixation techniques. I've taken care of many, many patients who've had a PPV and still will find just a little strand of vitreous that finds its way forward. And so making sure you're looking for vitreous, even in patients who've had a vitrectomy, is important. We do not want to put any traction on that retina. It will take a beautiful case and turn it into a retinal detachment. Now, this is a PVDF haptic. You can tell just by looking at the color of the haptic. So this implant is going to be a little easier to fixate, with a little more forgivability, if you will, on those haptics. They're not going to kink, they're not going to bend nearly as easily. So here we are back with our standard thin wall 30 gauge needle, making our sclerotomies, and then we'll use that right-handed paracentesis to find the first haptic. This is not so hard. It's the following one that's the challenge. And now this is the leap of faith. Once you get a fair amount of that haptic into the lumen of the needle, you release the hub. So make sure if you're using a 30 gauge needle, and I like to put them on a TB syringe to use as a handle, you make sure that is loose so that you can remove that hub, okay, leaving the haptic, or leaving the hub to kind of free flop on the surface. Second pass needs to be identical to the first. Get that into the lumen, and you can see that extra cannula with BSS is me instructing one of the fellows or residents as to how to do this case. Externalize, we almost missed it. Externalize the first haptic. Externalize the second haptic, and then you can cauterize. I'm just showing that that little caliper to people often ask, well, how much do you cauterize? For some reason, I thought I was measuring millimeters there, and I'm not. I'm just measuring what's on what's on the hash marks on the caliper, but you probably only cauterize 1 or 2 mm of the haptic. You don't need a giant bulb. In fact, you don't even want a giant bulb. And you don't touch the bulb with the battery operated cautery. You just get close enough that the heat begins to melt the haptic. So let's review. What have we learned? Well, there are multiple techniques that are available for fixation of an IOL in the absence of capsular support. Okay. The ACIOL is still a viable option in most cases, except where the iris will not allow placement or you have a large iris defect. Suture fixation of a hydrophilic acrylic IOL can show calcification, especially if exposed to air or gas, so be careful if you're using a hydrophilic acrylic IOL in somebody with retinal pathology. And even the hydrophobic acrylic IOLs, although better, now show some signs of weakness. So there is no single technique that is best for any patient. You have to take all of your knowledge and use that and make a good clinical judgment for what technique is going to be best for your patient, from ACIOL to iris suture lens, hydrophilic acrylic, hydrophobic acrylic, Imani technique, or suture fixation. It's your choice, but having the toolbox to make those decisions, I think, is important. Thank you very much for your attention, and I'm happy to take any questions.